Not a common condition. We see at least 4 to 5 in a year. After so many years, first time it was recognized in the 1910, and after so many years still we do not know why this is happening. If you reshuffle the bone alphabet Kienbock, it becomes a sick bone, and that's what exactly it is. It is a sick bone. And what happens? There is a loss of blood supply for unknown reason. The structure of the lunate changes, and because the change of the structure of the lunate, the adjacent bones start to migrate again. So initially the lunate has certain shape, gradually it becomes dense, then it starts to collapse, and then the adjacent bones start to rotate as well. And the adjacent bones to start rotating would mean, to start with, it is the scaphoid, and then the capitate starts to migrate more proximally. So these are the changes. As the changes occur, the alliance changes, and because the alignment changes, bones start showing osteophyte changes. So arthritis starts to increase in the adjacent bones. So in the first stage, the X-ray may look normal, but the MRI starts showing a dense bone, stage 1. As it changes further, the lunate becomes dense. And to highlight this, very important, you have an X-ray of the X-ray of the carpus and not the X-ray of the upper extremity. You see further, the lunate is now starting to collapse, and it collapses further, and it keeps collapsing. Like any other orthopedic problems are pain on palpation and restriction of range of motion and weakness, grip strength deteriorates. Treatment, no algorithm, जिसको जो मन में आता है is doing it. The treatment is biased, and most of the times the surgery works. And what surgery? I'll talk about it. Journal of Wrist Surgery 2016 says various treatment options are available, and there is no clear evidence or consensus of what to do. So everything is working. What has worked is, you do an osteotomy of the radius, take out about 2 millimeters of the radius from here, so this will shorten. What in a sense is happening is, the loading of the lunate is reduced. But also in parallelity, what is happening is, once you do an osteotomy, you are increasing the blood flow into that region. So you are making the whole area more vascular. So it is the shortening that is working, or it is the shortening causing more vascularity that is working, or both are working. We don't know, but this really eases the pain if you do a radius shortening. But that can be a problem if you do a radius shortening, because if you do a radius shortening, when the radius is already short and the lunate is long, first thing when you see the patient whether you should do a radius shortening is, see if the radius is long enough to be shortened. If radius is not long enough, then you go to something else, and that is called as a capitate shortening. So don't shorten on the radial side, do a shortening on the capitate side, so that again, in a sense, the amount of loading that is done on the lunate is reduced. STT fusion has been described, but the moment you do STT fusion on a new osteophyte start forming, because this moves abnormally, and arthritic changes start between this fusion and the radial styloid process. Other fusions have been described. I have not done it. Revascularization using one of these vascularized graft have been used. Again, I have not used, because these two options have worked: radius shortening versus capitate shortening. Excise the scaphoid, lunate and triquetrum, and let the capitate articulate with the radius, and this has really worked and eased the pain if the disease is advanced and is started to involve. Rest of the lunate is totally collapsed, friable, and it has made arthritic changes in the adjacent bone. I have not done wrist denervation. It has been described, but I have often combined ECRB tenotomy with one of these shortening procedures. What if the ulna is long? Now if the ulna is long, if you do radius shortening, this ulna is going to strike the lunate, and there will be pain on the ulnar side. In this situation, you do about 2 millimeter shortening of the capitate and put a K-wire, and this has solved the problem, and the pain is eased in these patients. What I have observed, we had a patient with Kienbock on both the sides, and we operated on one side. Surprisingly, the pain on the other side disappeared. So last word in the etiology is yet to be discovered. Hopefully in our generation, hopefully in our professional career, but this is an interesting observation, and the patient was an NRI, so we've lost to a long-term follow-up, but operating on one side made the pain disappear on the other side. We still don't know why it is progressing, but osteotomy works, proximal row carpectomy works. In fact, a lot of other procedures have been described, osteotomy of various angles, and everything has worked in easing the pain.